seal with a 1 by 1 centimeter defect, roughly, or even little more than that, from the anterior part of the planum sphenoidal, more on the left side approaching midline, in close proximity to the left side of the optic nerve, and the carotid is little away as it is little behind, and what we see is the picture is three-dimensionally in front of us.
Right, sir.
So the question would be, would the surgery change
Yes.
if there is intracranial hypertension? If all the signs that Satish had said
Sir,
just now-
your audio is not heard, sir.
So the question will be, will the surgery change or the method of the surgery change if there are signs of intracranial hypertension, the engorgement of the optic nerve, the flattening of the disc area? So let's ask Satish and Narayan what they would do if this has got an evidence of intracranial hypertension.
See, if this is intracranial hypertension, that's how the most of the spontaneous CSF leaks present as a manifestation of intracranial hypertension. And in those situations, pressure management is the key along with sealing the defect. Of course, sealing the defect is priority as to prevent meningitis or the infection to ascend. But at the same time, as you seal the defect, pressure may again build up, which is working as a releasing wall for the pressure. So in that situation, our protocol, what happens right now, the contents are herniated, the CSF is leaking. Even if you measure the pressure right now, the pressure may not be very high because the pressure is already leaking. It is not building up. Now, once you seal the defect, this high pressure is mostly due to fault in absorption of CSF, not due to overproduction. So once you seal the defect, the phenomena of high pressure may again develop. And that is dangerous as it may leak to the same side again, or it may, leak into a different side if you have really given a rigid seal. So high pressure management is very, very important. Now, what all you can do? First of all, to diagnose the real high pressure, our protocol is to do a lumbar puncture 24 hours after surgery. The reason being, our volume of the CSF is 150 ml, we all know. And more than 3 times of the volume of the CSF recirculates every day. So during the surgery and before surgery, whatever CSF which are drained out, it doesn't reflect the true picture of the intracranial pressure. So once you seal, we allow the 24 hours for the CSF to recirculate at least 2-3 times to give us a correct picture of the real pressure going on inside. So we do a lumbar puncture after 24 hours of surgery to give us a real picture of the true pressure, intracranial pressure going on, and that shows our further protocol. That decides our further protocol to deal with the high pressure. If it is too high, in our imaging protocol, this is not a complete imaging from our perspective. In our imaging, I have already mentioned we always need a 3D flare. That is inverse imaging of CSF. Means the CSF is dark and you can differentiate from sinusitis. Another thing we always add on to this imaging is MR venogram. MR venogram is a non-invasive investigation. Along with this, we advocate in the beginning the MR venogram to see if any venous sinus stenosis. So those are two important things to note in the beginning. So in high pressure situations, when the pressure is extremely high, about 30, you have to do immediately something to prevent re-leak. And in that situation, either you need a diversion procedure like shunting or something, or you need to look at the venous sinus if there is any stenosis or something preventing CSF absorption. This year, we have got 3 cases venous sinus stenting done because of the transverse sinus stenosis in those patients, which was the main cause of high intracranial pressure. Even if you do a diversion procedure, that is actually not the true answer than to treat the original problem which has caused high pressure. That is venous sinus stenosis, and that is something you need to rule out in very, very high pressures. If the pressure is not very high, between say 20, 25, something like that, you can put on conservative management by like Diamox or diuretics or whatever, and keep a close eye on the visual symptoms or high pressure signs. If it still starts developing any high pressure phenomena or signs or visual symptoms, whatever, even after the conservative management, then you have to think of a diversion procedure like shunting or anything. Out of the VP shunt or the thicoperitoneal shunt, nowadays we have given up thicoperitoneal shunt completely. Completely means 100% given up, because those are valveless and can overdrain. So VP shunt is the final answer in those situations. Narayan, anything you want to add on?
No, I agree with Satish 100%. This is our same protocol which we follow. So there are routinely questions asked, do you put a lumbar drain? We don't usually put a lumbar drain in any CSF rhinorrhea cases, except post-operatively you may require it for a couple of days if there is a high pressure and the patient has not made up their mind for further management. So you could keep that for a couple of days till your flaps take up and the healing takes place. But a definitive management for the intracranial pressure is the ultimate goal. Otherwise, you're going to get a revision of the leak again. Okay, however well you may do it, there's a high possibility you may still get a revision leak. So again, as Satish has described, I think that's exactly what we also follow. And we need to take care of all these aspects. So that's why, as a protocol, you need to have an MR. And that's why Satish keeps talking about an MRI to be done. It's not enough to do a CT cysternography and find out a site of leak and go and seal it. An MR is all gives you so much more information about the site of leak, your defect itself, whether there's a herniation of the brain along with it, the cerebral venous sinuses, the high intracranial pressure, and so on and so forth. So that makes it quite clear why MR is the preferred method of investigation in CSF rather than CT alone. CT, you can have bone cuts to sort of complement and see your defects and, look for abnormalities or, your anatomical variations.
Hello, Satish,
Yes.
Dr. Bharti here.
Hello, madam. How are you?
Yeah, fine, Satish.
So
Satish.
nice to hear from you. Yes, madam.
How many days of conservative management before you decide on VP shunt?
See, it all depends whether the need arises or not. Means, if any slightest of the sign of high intracranial pressure, like visual symptoms or like, persistent headache, tinnitus, or some sort of dizziness, or some symptoms pointing towards a high intracranial pressure necessitating investigation, is something the end point of the conservative treatment and thinking of VP shunt. Otherwise, no need. Secondly, I would like to mention one more point about here, as the question came, the need of vascularized flap. There are no clear-cut guidelines for the use of vascularized flap. Just for one thing I can always say, vascularized flap is always a better choice than a free tissue. For two reasons. Not only it gives a fresh blood supply to the region, it's a sort of primary healing. But at the same time, whatever free tissue you put can get necros, can invite infection, and can lead to meningitis itself. And if you are covered with a vascularized flap, you rule out that possibility of all those post-operative complications. So for the surgeon, it is always to stay on the safer side using a vascularized flap, number one. Now for the definite need of the vascularized flap, our choice is for certain group of patients, definitely, like this patient who has a leak from the planum, like Narayan has mentioned, which is associated with a cistern behind and could be having some little bit of the high pressure as compared to the other side. So this is something, a real indication for the vascularized flap. Other indications are in revision procedures. Whosoever is operated and if it is a revision, you can't take a second chance, and it is better to use a vascularized flap, whatsoever the size or site of the defect is. Third, in situations when you deal with larger defects, like you see Prabhakaran in practice is dealing with many suprasellar and all those tumors, clival tumors, creating bigger defects, himself creating bigger defects, and those are the bigger defects which always requires a vascularized flap to prevent, post-operative issues, meningitis, and all those problems where everything then the onus falls upon the surgeon as it is a result of an operative procedure and patient was not having a CSF leak before. And fourth is a situation when the patient is undergone, is a difficult patient for from healing point of view, like a post-radiation therapy or, elderly patient, whatever you say, in those high-risk situations, you always use a vascularized flap. Prabha, you want to add on? Agree with it?
Yes, I agree absolutely with them. I'll give you a classic example. We had a patient with a CSF leak, repaired. Well, the next day he was slightly drowsy. GCS dropped a little bit. Day 2, his GCS dropped to 11, and day 3, the whole thing just blew, re-leaked, and he was awake all over again. So this is a classical way of a high pressure leak. You close the hole, it's like a dam that is reaccumulating again. They start getting drowsy, and after 2 days, they just blow all over again. So these are the patients that we would require a shunting procedure and so on. I think it's very nice to have all three of us giving different ways, different opinions, and it's very useful. So if you have any questions, the three of us are here together. You can ask us, and we'll be able to tell you our different opinions and different ways.
Yes, agreed, Prabha. So what we can, I can extend to this discussion, this lumbar drainage, temporary lumbar drainage is as a method to facilitate the closure. At the site of closure, you are reducing pressure for some days so that your seal can take up easily. In the beginning of the period of healing, like 5 to 7 days, if the pressure remains low, your seal acts faster. That is the whole game of lumbar drainage. And you can use in high risk situation, like I mentioned, those high risk situation where you don't want to take a chance, and you can put a lumbar drain for a couple of days to reduce the pressure over the site of sealing and facilitate the closure. That's the whole idea behind the using the lumbar drainage.
Right, sir.
So our case is ready. In a couple of minutes, we'll be back with the endoscopic picture.
Okay.
ఇమీడియట్ చివరికి మన శ్రీధర్ ఆయన కార్డు వచ్చారు హైదరాబాద్ నుంచి వచ్చాడు అంతా నీతో వచ్చాడు మా ఇంటి వెనకనే ఉంటాడు మా విజయ్ దాంతో కొంచెం అక్కడ ఉంటే కొంచెం అదే ఆలోచన వస్తుందని ఇక్కడికి వచ్చేసాడు చేస్తున్నాను థ్యాంక్ యూ బాగా కాంటాక్ట్ ఉండేది ఇప్పుడు మానేశాను రావట్లా అందరినీ కలిసినట్టుంటారు ఓల్డ్ ఏజ్ లో ప్రాబ్లం అయ్యేది దేవుడిని ఎవరి కార్డు సరిగా
Hello.
Yes, sir.
Yeah. Am I audible, madam?
Yes, sir. You're audible, sir.
Okay. So are you getting any endoscopic picture now?
Yeah, we are getting the endoscopic picture.
So what we did, we packed with the marrow cell for a while, fogged in saline and adrenaline for the initial decongestion. And what we see is some important findings. See, as far as the anatomy is concerned, I'm in the left nose. The inferior turbinate, the middle turbinate looks like concha or something.
Okay.
It is.
Yeah.
And if you go behind what you see, this translucent pouch, that is the superior turbinate. Between the superior turbinate and the septum, this translucent pouch of meningoencephalocele is descending down. So
Okay.
this is what we need to deal with. So
Sir.
see the classical sphenoid, plenum sphenoidal leak with a meningoencephalocele coming down in the nasal cavity. So see this area medial to the superior turbinate and see the pulsatile.
Yes, sir. We can
See
make
the
out.
pulsations. Transmitted pulsations of the CSF. So in order for the exposure, like Prabhakaran said, we need a wide exposure like we get for the pituitary. And before that, I need to raise the hadad as well. Now this middle turbinate on this side is the big obstacle, which obviously I am going to cut off to acquire more space on this side. This is all decongestion everywhere. This is our preferred decongestion rather than infiltration. We use the topical decongestion everywhere. This initial application of adrenaline on the mucosa decongests so well that it prevents its further absorption in the systemic circulation. And the effect is almost equivalent to what you get with the infiltration. Only thing is you have to use it judiciously. This is a 1:2 concentration today. And see, I'm applying it everywhere on the mucosa. So give some time. Don't leave it. Don't pack it tightly. If you pack it tightly, it is counterproductive, giving more venous congestion. So it's just application of adrenaline on the mucosal surfaces it is. Simple application. And this will, give us a good field, I believe.
These are cut pieces of marrow cells, sir.
Yeah, so we use 2 marrow cell cut in different size pieces, approximately 8 to 10 pieces, and then you can reuse them throughout the surgery. This marrow cell, like this piece, once used, I will remove, rinse in the saline, soak in the same solution again, and then reuse, something like that. At the end of the surgery, you can use the same marrow cell pieces for the, cavity packing or something like that. Later. So now the first thing which we need to do is for the access to cut off this middle turbinate, and what I'm using here is the
Coablation.
Yeah. See, coblation is our preferred tool. Yes. This is to avoid the mucosal bleeding. In endoscopic surgery, whatever you do, your surgical field has immense value. By means of getting a good field, by means of reducing the bleeding, you can identify your landmarks much better. You can carry out your work more safely as compared to working in a bleedy field. Because your margin of safety in endoscopy